This is an informal lecture about cataract preoperative evaluation. As a broad overview, it's geared more towards ophthalmic technologists and students. But if you're a patient, there might be some useful information for you here too. So without further ado, let's meet up with our team. Okay. So I noticed I was talking over here in the past, but I should actually be talking there because that's what people see later, unless you have a question, which this is a very informal type lecture, so if you do have questions, just ask. Or if you're watching this online, put it in the comments below. Are we going to have Francis and Ivy join us?
Ivy's here.
Oh, Ivy's here. Good.
Can you hear me good?
Okay.
No?
So I did think about this morning how to best organize, because it, in some sense, is very simple. It's just cataract. But there's so many nuances to it. And especially when this is the main thing we do,
Can you hear me?
how do you best organize it? So the first part, I think, for everyone that is learning about cataracts is to kind of understand something about the anatomy. And that's a good way to explain it to patients. And it's a good way to understand it as you're doing your workup and testing. So if I were to draw a diagram of the eye, like our normal diagram, we organize all of this based on the structures here. So we have the cornea at the front of the eye, the iris, and this structure here is where the cataract forms. And then in the back of the eye, the retina. And remember, here is the cornea. If you go back to our other lecture about documentation in ophthalmology, the same thing when we evaluate a cataract is performed. We look at the structures, not just the cataract, we look at the structures around the eye, the eyelid, the cornea, the pupil dilation, the retina, because that matters a lot as to our surgical planning for cataract surgery. So when you're doing your workup, all that matters. And if you're a scribe helping to document this, all the rest of the features of the eye matter for our cataract consultations. A patient might come in for a cataract consultation. They already know they want surgery because their optometrist said they need it, but we still have to look at everything else. That really matters in terms of our surgical planning and our technology that we use for surgery. Questions on just general overview of the anatomy? We're going to go into more details on this next. Okay. So first off, if you remember from our documentation lecture, we want to look at the eyelids and eyelashes. Reason being, if there is ectropion, if the eyelid's turned out, if there is entropion, if it's turned in, if there's eyelash trichiasis, then that matters, because if the eyelid's turned in and there's eyelashes touching the cornea, then it's going to increase the risk for endophthalmitis or infection after cataract surgery. So oftentimes if there is an eyelid issue like entropion, we want to make sure that's managed in a way that won't interfere with our cataract operation. But much more common than that, especially here in the desert, is our patients that have meibomian glandular disease or dry eye disease. This is the first thing that we look at, if you look at our documentation, is the structure outside the eye. In 2019, the Academy of our Cataract Society met, and we revised our criteria for cataract surgery. We found that the people that have unmanaged dry eye have a slower recovery. They have a harder time recovering, and we're more likely to be off target with our refraction when there's unmanaged dry eye disease. So in that 2019 meeting, we revised our criteria for cataract. We always want to manage dry eye before cataract surgery. We're more likely to have an easier recovery. We're more likely to be on target with our refractive target. So if you have someone with unmanaged dry eye disease, you're going to measure a lot of astigmatism. You're going to measure some unstable tear film, and then our implant power can be off target. So that's step one. Make sure we manage the dry eye before we do any cataract. And that'll be a different lecture on the dry eye. The next, remember we look at conjunctiva. The conjunctiva is the white part of the eye. We're looking for inflammation, injection, hyperemia. That goes to that ocular surface evaluation again. And then we look at the cornea. I can't use C again, so I use a K. The cornea is very important. There's the front of the cornea, there's the back of the cornea. The front of the cornea, or the anterior surface, we are looking for issues like pterygium. We're looking for a condition called EBMD. Have you heard of that before? It stands for epithelial basement membrane dystrophy. It's over the years gone by different names like Labrador keratopathy. One of my favorites is MAP dot fingerprint. I like that because that describes the appearance on slit lamp. It looks like map or dots or fingerprints on the cornea. And if you're watching this online, I'll try to input some pictures of that here. So Alan, if you're watching this, there'll be a photo here. This matters because if there's a pterygium or if there's any corneal distortion, if there's something called keratoconus, this can also cause issues with our cataract operation. The epithelial basement membrane patients are more likely to have abrasions. We do have to watch them very carefully post-operative for that. And also, if there's more significant MAP dot fingerprint dystrophy, then they're poor candidates for multifocal lenses. They're also more likely to need glasses after surgery. In fact, the really severe ones, we will do a keratectomy. We'll do a superficial keratectomy to try to smooth the cornea out prior to cataract. And then we have the keratoconus patients, the patients that have a history of LASIK. And then finally, as we go deeper into the layers of the cornea, the endothelium, there is endothelial dystrophy, and the most common for that is called Fuchs corneal dystrophy. So these are all the comments that we have to look at all of these issues. Fuchs corneal dystrophy, you will see comments like guttata or bronze pattern on the corneal endothelium. And sometimes we'll comment, we'll say there's a little bit of guttata, there's trace guttata on the cornea. Patients with Fuchs dystrophy also are poor candidates for multifocal lenses. They are more likely to have a slower recovery because the cornea is weakened, and often, if it's a longer surgery or a larger cataract, they'll have corneal swelling on the first day or two after surgery. So it takes them a little slower to recuperate from surgery. These are very pertinent features to rule out, or to at least look for, before we even look at the cataract. As we work deeper in, we're going to look at the iris. On the iris, we want to look for features of floppy iris or intraoperative floppy iris syndrome. We're going to look for a smaller pupil dilation. So back around 2005, there was a red alert that was sent across the country when we realized as cataract surgeons that patients that have a history of Flomax or tamsulosin had high risk for floppy iris. And we were seeing this surgically, we were seeing the iris during surgery have a lot of movement, or even become so floppy it would prolapse out of the eye. And this caused correctopia, this caused iris damage, and made the recovery horrible for the patient. And also, postoperatively, these patients had glare issues. If you haven't already, we do have at least some video on our channel for this about what do we do with the small pupil. There's a video for that. I'll try to link that up here. We also have a video about if it does prolapse, if the surgeon wasn't ready for it and it prolapsed, how do you repair that? So some of these issues can be repaired, but the idea is not to let it get to that point. The idea is to recognize these issues beforehand. You want to also ask, are they using Flomax? Do they have a history of prostate issues? That's part of our cataract evaluation. Have they ever been on Flomax before? They might have had a prostatectomy because they had prostate cancer 5 or 10 years back and they're no longer on Flomax. But maybe if they used it 10 years ago, that's enough. Even if they stopped 10 years ago, that's enough to put them at risk for floppy iris. So in these cases with a small pupil, it matters in our surgical planning because now we're going to make sure we have on standby iris retraction devices. Whether it's a Malugan ring or a Visitech ring or iris hooks, we can often stabilize the iris with our new technology during surgery. So this matters in our surgical planning. How well do they dilate? We always want to use the good dilation for the patients for a cataract eval. So the patient will come in and they'll say, well, I already know I have cataract. Why do I have to be dilated? Well, this is the reason. We want to evaluate how well they dilate during surgery. And they'll say, I was already dilated. My other eye doctor dilated me. Why do you need to do it again? This is the reason. Another reason, we want to look at the rest of the eye too. We don't want to miss anything. So then we go to the cataract, and I think we're gonna I think there's enough room to talk about that. So the cataract, there's many different types. If you look in our documentation, we don't just say cataract. We're gonna specify the type of cataract because different cataracts develop at different stages. Some cataracts cause more glare than others. Do you know in our documentation the most common that we see here?
Nuclear sclerotic.
Yes, that's the nuclear sclerotic cataract. Let's go into details about that. I'll usually document that something like NS or NSC. Different places might write it differently, but that's how I write that because it's easy to write NSC instead of nuclear sclerotic age-related cataract. You can just type NSC, there you go. We'll grade it on traditionally a scale of 1 to 4. Stage 1, I would say, is mild. Stage 2 is getting close. 2 to 3, yeah, we're probably at that point we start to have symptoms. And this one is your age-related. So this type of cataract typically will be your average mid-70s patient. It does cause a lot more issues with glare at night, maybe problems with more distance vision. It doesn't always have as much issues with the near vision. So sometimes we'll see a patient, they are myopic, they're a 3+ nuclear sclerotic cataract, but they still can read fine. They're just having trouble at night. So interesting, this type of cataract, it's more age-related, and it causes more issues with the distance, less so at near, interestingly enough. What's another common cataract you see? Moving on.
Posterior subcapsular.
Yes, posterior subcapsular. I'll try to put photos of this on the video when we upload it. So this is age-related here. Now, do you know about the posterior subcapsular cataract? Do you know what that's associated with? The number one association that you'll see is diabetes. You'll see patients with this, and they might be 50, they might be 40 or even 30, but whenever we see this posterior subcapsular, we always ask, have you been tested for diabetes? Because there's a good chance there's a high association. So the diabetic patients get their cataracts at a younger age. They might get it in their 40s or 50s or even younger. We'll have a 20-year-old who's had type 1 diabetes since their teenage years, and 10 years later they're 22, 24, and they already need cataract surgery. Another association is use of steroids, like corticosteroids. These are our patients you'll see who had bad asthma in life or COPD. These are our patients who had rheumatologic disease. These are the patients who may have had cancer. And a lot of the treatment that's used in these conditions uses high-dose corticosteroids. And these patients will get a cataract very quickly. We just had a patient who we saw in November, and she was 25. She was doing fine, but she was going through chemotherapy for lung cancer. Right after the holidays, she came back in January, and she was 20/80. She went from 20/25 to 20/80 in a matter of a few weeks because she was on very high-dose steroids for her lung cancer. So these cataracts happen at a younger age. These patients also have very horrible glare. This is probably the fast onset. So this is fast onset, lots of glare, and you're going to see our younger, like this past year, we've had several 50-year-old patients with these, and they come in, they're 50, but they can't see, they can't drive anymore, and it happens very quickly. Next type, do you know a common one? We're going to go to the cortical cataract, or the cortical spoke. That's another word for it. I'll try to put a picture of that here. These are interesting because they start from the periphery of the cataract and then move inward, and they look like the spokes of a bicycle tire. These are usually associated with higher rates of glare, and usually these are a little more slowly progressive as well. Often when I see cortical spoke cataracts, they're usually combined with a nuclear sclerotic. So the cortical spoke patient, it's usually a mixed type of cataract. We'll just put one more category here. I'm not going to go into too much detail about that. That would be the ASE, or the anterior subcapsular cataract. These often I'll see they may have a history of trauma, so our traumatic cataracts, more like this. So in a nutshell, that kind of summarizes some more of the common cataracts. Of course, there's several subtypes of cataracts, like cerulean cataracts, like congenital cataracts, but those are less often seen, and these are more common categories. So you'll often, when you're in the room and we're doing an evaluation, you'll often hear us comment on all of this. We might say, even if they don't have gutata, we might say there's no gutata, the pupil dilates well at 6 millimeters, and there's a nuclear sclerotic cataract. We also want to comment, is there something on the anterior capsule or on the pupil border here and here? We want to comment on something called pseudoexfoliation. Why is that important? It's not visually important. People that have pseudoexfoliation have no visual symptoms, but it's important for cataract surgery because, number one, they often have loose zonules. Remember, the zonules are what support the cataract. So if we see pseudoexfoliation, we want to be sure, as we plan on surgery, that we're very gentle with the operation, that we don't press on the cataract while we're there, so as to safely remove it without causing a capsule rupture or loss of lens material to the back of the eye. Second association with pseudoexfoliation, there often is glaucoma, and if you remember, glaucoma affects the optic nerve. So pseudoexfoliation, really good to look for that in your cataract evaluation. We're going to look on the anterior lens capsule for pseudoexfoliation debris. I'll try to put a picture here of that. And we also want to look at the pupillary border. Is there pseudoexfoliation debris there? That'll mean if you see this commented, we're going to be very careful when it comes to the cataract operation not to put undue pressure on the cataract. We don't push. We want to be gentle around the zonules, and we even want to think about some of the maybe laser options for cataract or the chopping techniques for the cataract removal. As we go a little deeper, the vitreous. I always comment on this because many people might have a vitreous floater and it's there, but they don't see it because the cataract is blocking it. And then we do cataract surgery and all of a sudden they say, oh, I have a floater and I never had it until you did my surgery. Well, we comment on it beforehand because we'll mention it. Oh, sir, you have a floater, it's off to the side, and sometimes people may see it more clearly after we unmask it with cataract surgery. So that floater we want to look for. We also want to look for vitreous signs of detachment like the Schaefer sign or tobacco dust in the anterior chamber. We want to look for hemorrhage because that will be a smokestack or maybe a red flag. There might be something wrong with the retina. Let's go to the retina now. The retina is very important to look and evaluate before you do cataract surgery. If there's a retinal detachment, if there's like we just had, a patient with a choroidal melanoma, well, that really matters because how do we do our cataract in situations when there's a retina disease? I will look all the way around the retina. We just had that patient in February. He came in and he was referred by the optometrist for cataract. And yes, he had a cataract, but he also had a choroidal melanoma. Well, now we have to make sure we address both issues. We want to make sure the melanoma is taken care of and the cataract, and not just focus on the cataract only. And let's say the retina has macular disease like epiretinal membrane. Or macular degeneration. These factors matter because now it's going to alter our surgical plan for the implant technology that they qualify for. So just like if they had corneal disease, if they have macular disease, such as a macular hole, an epiretinal membrane, macular degeneration, we definitely don't want to put a patient like that in with a multifocal or extended range lens. And then we'll finish off with the optic nerve here. The optic nerve evaluation is important if there is optic nerve cupping or increased cup to disc ratio, then that points to glaucoma. Why does that matter? Well, I guess you can reference our other lecture about glaucoma overview, but it matters for our cataract because if they do have glaucoma, then we start to consider while we're at their cataract preoperative appointment, do we also consider MIGS surgery for them too? So if they have glaucoma, it's going to change our surgery management with the cataract. Do we do combined cataract with MIGS? It's very interesting. I always think it's important when we look at the cataract, not keep our blinders on. We have to look at the whole eye and be systematic about it. And you'll notice our evaluation is a checklist every single time. We look at the eyelids, we look at the conch, the cornea, iris. We look at the whole feature. The entire eye matters for our structure of the cataract. Kind of a broad overview of the anatomy in our cataract evaluation. If there's no questions on that, we'll just erase and go to the next topic.
Oh, I do have a question.
Question.
Fuchs. What does it mean when you note Gutata or bronze?
What does it mean? Well, it's more... So if you didn't hear the question is, what does it mean Gutata versus bronzing? It's more the clinical feature, meaning Gutata is the very earliest stage of Fuchs dystrophy that we can see clinically. It'll look like tiny dots on the corneal endothelium. As the Gutata become more numerous, it has a bronze, classically we call it the beaten bronze appearance. And it has a look that reminds you of a shield of bronze that's been hammered. So I have this bronze brownish color that has these little hammer effects on it, or hammer spots. I'll try to put pictures on this online too that I'll just pull and put, you can reference that. At least the way I look at this is how much is the extent of Fuchs dystrophy. I might say it's mild, maybe level 1+, maybe more moderate 2 to 3. And the really bad Fuchs patients, we're going to see not just the bronzing, but the edema. And you'll see me write things like corneal folds or Descemet's folds. It's so swollen that the Descemet's membrane looks wrinkly. Literally wrinkled, almost like when you go in the swimming pool too long and your fingertips look wrinkly. And that's what we'll see with the swollen cornea. It gets really swollen and the Descemet's membrane looks wrinkly. Okay. For this next section, I want to maybe go over our workup. So this is geared more towards our technologists. How do we do a cataract workup? So kind of have a broad overview of the anatomy from the last section. This is our workup. First off, like our documentation lecture, so that's a good foundation for this. What is the first thing for every doctor visit that we look towards?
Vision.
How about chief complaint? Chief complaint, that's the first thing. Whether you could go to urgent care with a sprained ankle. Chief complaint is, I sprained my ankle. And cataract patients, their chief complaint, what are the common symptoms? So that's why I put it on here, because we're going to talk about some of the common symptoms. Let's brainstorm that.
Glare.
Glare, good, awesome. What's another common symptom?
Difficulty driving at night.
Driving at night. What are other common chief complaints?
Can't see. Yeah, visual loss. Vision loss.
Blurry vision. Loss Vision. Our patients say, I can't see my golf ball. They'll be in the restaurant. This is a really common one. So we get the drive at night problems because in the desert there's no street lights. They can't see their golf ball. Another one is they're in the restaurant and they have to move their chair because if they're seated, so the light from the windows coming in the morning or the evening, dinner and breakfast, they can't see because the glare behind the person, they can't see the person across the table. So that glare is a really big one. Another really interesting comment, people will say, I have double vision. They'll say, I see double. And you're like, oh no, do I have to do a neurologic workup here? Is it horizontal? Is it vertical? Well, ask them a little bit more. What do you mean double? The cataract double vision patient will describe, I see multiple images. And the classic one is they're going to look at the moon and they're going to see 3 moons. Or maybe 4 moons. And I joke with them, I'm like, okay, when it gets to 5 moons, then you know it's time for surgery. Because the cataract is going to split the rays of light into more than one image. So the difference between the diplopia cataract patient and the diplopia neurologic patient, like a cranial nerve 6 palsy, the difference is the cataract double vision patient is going to say, when I close one eye, it's still double. Versus the neurologic double vision patient is going to say, when I close one eye, I don't see double anymore. That's one really good question. Just good to go back to Kate's question. What do I do with the double vision patient? Well, you want to ask them, is it horizontal, vertical, diagonal? Does it go away when you close one eye? Because if it's still there when they close one eye, cataract can be a reason for that. It's one of the symptoms of it. Or double vision. And this is going to be monocular, meaning when I have only one eye, it's double. Those are the symptoms. And of course, you want more detail when you ask them the rest of the history. How long has it been going on? Is it your left eye, your right eye? You know, what makes it better? What makes it worse? Have you tried new glasses yet? I really like in my history of the cataract patient to find out at where in their life does it bother them the most. Is it mostly golfing? Is it mostly driving? Is it when they're crocheting? So it's more of an open-ended question. And the reason why I like that is at what points in your life do you see this most? Because it's open-ended, and then you get an idea about their personality. What are their hobbies now? So I think in my cataract history, I like to know about their hobbies. I like to know about what they do to enjoy life and how the cataract impacts the hobbies. Because let's say they're still working. Let's say they're a pilot, for instance. Well, the cataract pilot patient, it's large. It's very important to make sure we keep the pilot's vision or the truck driver's vision perfect. If we know they're a pilot, an engineer, or a nighttime truck driver, it also helps in our lens implant choices. Their personality and their employment, their hobbies matter. So I think in our history of our cataract patient, put that in your history as you get that history from them. Their hobbies, their work, what is their personality, what do they like to do? That's part of our cataract history. Okay. The next section is people ask, at what point how do I qualify for cataract surgery? So as a tech, you're going to get some of your workup for that, and the main thing is vision. So we're looking at our visual acuity. On the visual acuity, it's nice to get their uncorrected vision. Not that it's hugely important, but let's say your uncorrected vision is 2200 because they're -3 refraction. But now we're going to check their corrected vision. We're actually going to refract, and with correction, they're 20/25. This patient will come in and tell you, I can't see, it's just hard for me to do. Well, have you tried glasses? Because if you did glasses, you might be able to function well, and great. Now we definitely don't want to do surgery if you can correct it non-surgically. So uncorrected, corrected is important. A lot of times we'll have a patient who might be +3. And the same thing, have you tried glasses? Well, glasses corrected you, so let's not jump to surgery because you might be able to postpone it longer just with some glasses. And they'll argue, they'll say, I never used glasses in my life except to read. And you're like, well, you're on the next phase. A lot of the hyperopic patients, when they get to their 60s, are now needing not just the readers and the computer glasses, but now they need the distance, and they're going to transition into the next phase. So this goes on this category of lens dysfunction. In the past, you might hear the topic, people say, well, the doctor said my cataract wasn't ripe. And so that word gets thrown around a lot. But I think more of a gradual development of cataract is important to think of. It gradually develops through our life. Lens dysfunction starts the moment we're born. Because the moment we're born, the lens inside our eye, so that's going back to our diagram of our cataract, the cataract starts to harden and weaken throughout our life. Our hyperopic patient will first start to see the first sign of lens dysfunction in their 40s, 50s, and now we start to get them in readers. And then when they get to their 50s, 60s, now they're in readers and distance, they're into bifocals or progressives. That's going to be their 50s, 60s. And then classically, once we get really bad lens dysfunction, as this gets worse and worse and worse, and the vision declines and the lens hardens and no longer is flexible, now we're looking at cataract surgery. And I think classically in our practice, it's our 75-year-old on average. So it's a gradual decline, step by step, throughout our life. So at what point, classic training for cataract qualification, do you know what vision we're looking for on that? So when do we decide cataract? Correct. Good job. So best corrected, visual acuity, maybe 20/40 or worse. That's classic training. Now, another secondary criteria would be, let's say we are our glare. Let's say they're 20/30 minus a couple, they're not quite 20/40, but let's say their glare is 20/80 or worse. I think this is classically what most would consider some of the general criteria for cataract surgery. And obviously it's going to depend on other factors like the patient's hobbies, their personality, their employment. Maybe our pilot cataract patient might be 20/30 plus 2, but he's about to lose his license and lose his career, and he's only 50 years old. So our cataract patient who's a pilot, we may end up doing surgery a little bit sooner just because it has a bigger impact on his quality of life. So quality of life is actually, in my mind, maybe the most important. Does it affect your activity of daily living, or ADL? So these are the numerical evaluations of cataract candidacy, and this is more the subjective, quality of life. We just had our pilot from Nevada last year. He flew out, we did his surgery, and then he flew back home because his quality of life, he was maybe 20/25. It was really starting to affect his flying. He had 20/80 glare, but he was still 20/25. I mean, good enough to get by, but he really needed that surgery. One more step and he would have lost his license. Quality of life, I think, is a really big part. That's why in our history it's so good to pull that from the patient. How much is it really affecting them? And what is our chance that we can get them better? If you have someone who's 20/20 and they say, my quality of life is horrible, I can't see, and you're looking at them, you're saying, well, you're 20/20, I can't really do better than that. There might be other issues, and there often is. There's often dry eye disease, there's maybe history of LASIK, there's mild corneal ectasia. So if you have someone who's just begging for surgery, but you're looking at them and they're 20/20, you really have to think hard before doing anything surgically. There's probably something else going on besides just the cataract. That's why in our cataract workup we want the uncorrected, we want the corrected, we want the best corrected, we want the glare, and one more thing that at least we do in our practice, we want the potential acuity measurement, PAM. Why is that important? Well, let's say we have a patient who didn't realize it, but their whole life they may have had underlying amblyopia. That means a lazy eye. Or let's say it's a big cataract, even more important, or a large cataract. Even more important, we want the PAM because that will tell us what is their potential, at least what we can measure. Sometimes you'll run across some of the patients, you try the PAM, they just can't see it. We're trying to shine the light and they can't see up, down, left, right. They can't see anything on it. Well, it's not the most reliable, but let's say you have a large cataract and someone who's 20, their vision is 20, 100, and you do the PAM and the PAM improves to 20/30, well, great prognosis. Well, Our best corrected is 2100, but with the PEM, we can now tell the patient, hey, there's a good chance that with your surgery, we can get you to 2030. Then you'll get your driver's license back. So it's a good way to kind of help guide the patient through prognosis. PEM can also be helpful for your macular degeneration patients. Let's say your vision was 2100, but our PEM only gets them to 2050. So now we can counsel the patient, well, it's going to help you. Cataract surgery will get you only to 2050, though. At least that's what we're predicting. So your macula is going to be the long-term problem we have to deal with. So PEM, I think, plays a big role. It helps us to counsel the patient on their visual prognosis. Make sure on all the cataract patients you dilate, like we talked before. So I think that's your workup for the cataract. I don't know if you had other questions of that, but if not, we're going to move to the next section. Okay. So next section, we're going to talk about lenses. And there's huge categories of lenses for cataract surgery. There's multiple companies, and it's very complicated. But I think once you understand general concepts, it's actually not too hard. It kind of boils down to just a couple lens categories in general. But before we talk about those categories, I think it's important to understand the concept of focus and defocus curves. So we talked a little bit earlier about lens dysfunction as it pertains to our vision as we age. And if we were to graph that on a scale, let's go ahead and do that. We're going to do several graphs here. If we graph, for instance, a defocus curve for a 20-year-old healthy person, on the x-axis, we're going to put distance. So this would be like near focus. This would be far focus. This is across the room. This is to watch TV, to drive. Near would be reading. And then intermediate, this is like arm's length. This would be like your phone, your computer. So if you are 20 and have emmetropia, you don't need glasses, your defocus curve is probably almost the whole thing. You can see all of this, right? And whether you're near or far, you can see all of it. Maybe it drops off if you bring your hand really, really close. At some point, it drops off, like it gets slightly out of focus. But for most things, a 20-year-old is going to have a really nice defocus curve. And this is maybe quality or contrast. Quality and contrast. Let me label it up here. Now, when you get to your 50s and 60s, it's going to be different. For the emmetrope, all of a sudden the near vision, the intermediate, is gone. But the far will still be good. So our 50-year-old is going to look more like this. It's going to drop down. When they hold a book up close, they really can't see it. If they hold a menu at the restaurant arm's length, they might see it if the light's good, but it's not going to be nearly as good as a 20-year-old. And that's why our 50, 60-year-old patients are wearing readers to bridge that gap. Now, once you get to your 60s and 70s and the cataract starts to occur, everything across the board is diminished. The color, the quality, and the contrast drop. So they're only going to see it maybe at 50%, 30% of normal. Let's put it, 30%. Let's say the cataract is a level 2 or 3 and they're like this. So this is our 75-year-old classic cataract patient. when they look far, they're only getting so much quality and contrast. Up close, it's horrible. They're in glasses for everything at that point. And even for distance, with the best glasses, they still can't bridge the gap. That's as good as we get. Now we take that 75-year-old and we look at their lens choices for implants. Let's start with the basic lens. So how do I graph that? We're going to do the same XY axis. Let's put our awesome 20-year-old vision up here. We're going to take that 75-year-old with a cataract, and we're going to put a lens in there. And then far vision. Let's say we use just a basic lens. The far vision will be nearly as good as a 20-year-old actually. It'll be like this. 75-year-old with a basic monofocal lens. Ooh, let's spell that correctly. Now they're going to go from where they used to be, which is about here, and they're going to go up to here. So awesome, they're going to love it. They're going to say, wow, that was the best surgery ever. I now can drive at night. I can see my golf ball. Awesome. So they had a really nice improvement, a big jump in vision. And now let's do another graph. Same patient, but let's say we did a multifocal lens. So here's our 20-year-old vision. And now we're going to take our patient with the multifocal, and the classic multifocal, for instance, is the Panoptix lens. We're going to take our patient who's seeing only maybe 30%, we're going to improve it, but it's only going to go to here. It's only going to go to here, and it's only going to go to here. So we're going to have 3 points. And if you notice, each point maybe isn't, it's not to scale, but each point is not quite as good as a 20-year-old. But a lot better than when they started down here. Their original graph was like this. So they're going to have improvement in the distance, they're going to have improvement in the intermediate and the near. So your 75-year-old with a multifocal lens is going to love it. They're going to say, awesome, I see so well. I was here and I'm here. I was here, 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 here. At every point along their defocus curve is going to be much better. Now, it probably won't be good as a 20-year-old, because a 20-year-old has this range, this kind of in between the intermediate near, and the 20-year-old can go a little bit closer too. And the 20-year-old up close can even hold the book right here and see it, but not the 75-year-old with the multifocal. So when we talk about multifocal lenses for a 75, 80-year-old, they are thrilled with it in general. But let's say we take our 50-year-old and we take our 50-year-old and we put a multifocal lens. Look what happens. They might get a little better near from here to here, but their distance suffers. It won't be as good as a 50-year-old eye. And the multifocal lens can often have side effects like halo and glare. So when we talk about a 50-year-old who comes in, like we just had on Wednesday, and she said, look, I can't wear glasses. They're annoying. I don't want to wear them. I can't see my phone. Can you do surgery? And we look, there's no cataract. She's basically asking to go from emmetropia, put a multifocal lens to get a little bit of near, but there's a sacrifice of distance. So our 50-year-old with no cataract, no issues, who's like, has a curve like this, I talk them out of surgery. I say, don't do it. Because you're going to love the near. Well, it'll be better than what you have, but it won't be as good as if you put reading glasses on. It won't be as good for your distance. There's too much trade-off, too much sacrifice. As good as the technology is, it's still artificial, it's still man-made, and it comes at a cost. Loss of contrast. And some studies say maybe 8% loss of contrast. So what does that mean? For the 75-year-old, their contrast is improved because they used to have a cataract. But our 50-year-old would notice the decline with the multifocal lens. They would see the letter E, but they would see a halo or edge artifact to it. That's why that discussion is really important on our pre-op. So Kate, as you see these patients, we really make sure to talk about the slight decrease in contrast, the slight increase in glare symptoms at night, and all this difference, this gap between here to here, this quality and this quality, it can be amplified, the gap here. This is amplified in patients with dry eye disease, with corneal pathology, with any macular pathology. So if they have any of these issues, that gap can be even larger. And that's why whenever they have severe macular disease or corneal Fuchs dystrophy, we don't want to do this to them. It's going to make them worse. That concept of defocus curves, I think, is helpful, right? Now you can understand why we kind of gear some patients one way or another. For instance, you have your patient who's a pilot or a truck driver. We don't even want to do this to them because their contrast is going to be reduced. They might get 20/20, but they might have a reduced quality. And for someone who's driving at night or flying a plane, maybe not a good person to put a multifocal in. One more person, and this is the same 75-year-old, but let's say we didn't do a multifocal. Let's say we did an extended range lens, classically like Symphony or like Vivity lenses. So let's draw that. It's going to be about the same, maybe a little higher peak, and then it stays up pretty high because it stretches that focus. Intermediate's good, but near drops off. So the defocus curve is slightly different for the 75-year-old with a Vivity lens or an extended depth of field lens, slightly different. So compared to the multifocal 75-year-old, they're going to have a little better vision in this range. That's why the people who love this EDOF lens, like Vivity, they're going to be the ones that are playing tennis or badminton or pickleball, because they can actually see the person across the court. They can see the person at the net too. Whereas someone with the multifocal, it would be a little hazy if they're up at the net. The other people who like this, like we have some of our card dealers at the casinos here, they like the EDOF lenses because they can see their cards if they hold it far enough, but they also can see the person at a longer table. So this is the range where I think the Vivity patient is going to love it. So you're talking not quite 20 feet away, but more that 10 feet, 6 feet range. They do better. It's a little better curve. This drops off in that section. Hopefully that makes sense in the lenses. And these are the broad categories. So do we do a monofocal, multifocal, extended range like Vivity?
So the younger patients, the 50-year-olds, the pilots and so forth, do they get best results with the basic?
Right. So how do you manage this? Well, you really have to look at the patient. The 50-year-old pilot, who definitely the priority is quality contrast, right? That's the priority. You may not want to do an EDOF or multifocal. You may want to talk to them about that because there is a slight drop in quality, a slight drop in contrast. To stretch that focus longer, we're going to lose some of our contrast. So that's a big question for our patients is, are you looking to be free of glasses and have the independence and not have to grab them in the morning and not put them on when you're out playing pickleball? Or are you looking for the best quality vision, the best contrast? And you're right, a 50-year-old pilot, like the one who flew in from Nevada, we did a basic lens. We didn't want to sacrifice and have the issue of that gap from best possible by splitting the image or stretching the image focus with an extended or multifocal. Remember, the multifocal, this lens classically has little rings of focus. And when you look at them, each ring is going to split the light from near, intermediate, and far. This ring will be near, this will be intermediate, this will be far, and so on. And you are actually overlapping several focus points altogether. And it does cause some image degradation.
Because I had a pilot case, not here in my previous job, so the question was about the best glasses she could get. She was in her 50s, pilot, active pilot, and she said, I don't care about the distance. I only care about what's in my plane on the dashboard.
Okay.
Plane. So that's what I need to see clear. I don't care
What?
about the sky.
Wait, so you had a pilot who didn't care about distance?
That was wow. I'm like, I don't know what to do.
Well, you're right. They have to look at their maps. They
Yeah.
have to look at their dials. I don't know what to say about that, because pilots need everything. I mean, they need the best vision. Our pilots need everything. That's interesting.
Yeah, that was a big struggle.
But the 50-year-old is going to say that, because the 50-year-old is comparing their eyes now to how it was 10 years ago when they were 40 and they were okay to read their maps, they were okay to see their dials, but now that they're 50, they're transitioning into presbyopia territory, and they have to adapt. They have to start to learn to use the bifocal. See what I mean? That 50-year-old presbyope with no other pathology is going to have these struggles.
So it's more like they don't know what's coming.
Yeah, and you just have to brace yourself, because the next 10 years, you're going to have to learn to change, because we are not 20 forever. This curve starts to shrink. It compresses through our 50s and 60s. It goes from here, it just shifts even further away. And gradually over the years, we start to adapt.
And for the panoptics, to which patients would you confidently advise
Oh, yeah.
panoptics? Because the younger ones, obviously, they're going to make sacrifice with quality
Yeah.
vision, and the older ones, the 75-year-olds, they often have AMD and things like that.
Well, you want to, for anyone that's considering a multifocal, whether they're 50, which we've done, it's okay, 40 even. We had 3 months ago, we had a 42-year-old. He went with Panoptics. You want to really make sure they understand the nuances and the trade-offs involved with this. You really want to get to know them personally, and that's why it's a very intimate discussion we have on our cataract consultations, and especially on the pre-op, when we talk about these surgical options, because the patient's personality really matters. If you have a really OCD engineer or retired surgeon, they're going to notice, hey, it's not as good as it was when I was 20, and I like my detail. I want to see it when I'm working on my model of my planes at home. I want to see when I'm crocheting, versus the patient who maybe is in a wheelchair and they're not reading books. They're just, spending time with family and going to the park. They don't need that extra gap in quality for focus. They're not building model airplanes, and they're not, they're not flying airplanes. They're not a sniper in the military. They just want to be able to see their grandchildren, go to the park. So there's a difference. So personality is how you decide. You have to look at their hobbies. You have to look at the rest of the eye pathology. So anything with eye pathology, we're going to exclude from multifocal. And anyone with a personality or hobbies that wouldn't be conducive to this potential decline in contrast, we're going to exclude from the multifocals. That's how you decide. We could have, like our 42-year-old, he just hates glasses. He doesn't want to deal with it. And he's like, well, this is an investment for the rest of my life. I'm going to go with the multifocal because I I want to be like how I was when I was 30. I can see near and far. So it makes sense for some situations. The trouble is you can do a multifocal, you can end up 20/30 or 20/25. Now you can read and see far, but you're not going to be perfect, crisp vision like someone who's 20, because there's a decline, there's a little gap. That's why you see me in glasses, because I know there's no perfect lens yet. I know with even a multifocal, and it's costly and it's state of the art, multifocal isn't perfect. Honestly, I'm waiting for the one that does night vision, that does telescopic vision, that does slit lamp. Can you imagine if I had an eye implant that allowed me to do a slit lamp exam without a slit lamp? Microscopic. That's what I want. So until the technology is at the level, my expectations are sky high. I'm the worst candidate for cataract surgery because I want everything. I want like the infrared night vision, zoom in like a slit lamp, and see far like a binocular. And we don't have anything near that. So that's the personality. I would be a cataract surgeon's nightmare as a patient because I want it all. I want a defocus curve that's better than a 20-year-old. That's what I want. If I'm going to put my eyes through the risk of surgery, I want to be sure that I'm better than that. I hope that makes sense. I mean, how do we decide? You really have to gauge the patient's personality. You want to look at their pathology here too. Let's go over maybe 2 more nuances to the cataract evaluation on the pre-op assessment that will matter on our discussion. So I'm going to erase this, we'll go to the next phase. So yeah, the superhuman vision, near, far, see up close, see far. If you have a patient that has an expectation they'll never need glasses again, and they want that perfection so they can go to the shooting range and shoot the wings off a fly, and they can see up close and read the numbers on all their pill bottles and not have any nighttime side effects. If their expectations are that high, then they need to wait on surgery. The technology just isn't that good yet. So you have to gauge that personality on the pre-op. So a couple more nuances to surgery. One is astigmatism management. This is really important because if you haven't already, we do have, I think a couple years ago during the pandemic, I did a whole discussion about astigmatism and toric lenses with cataract surgery, which you can always reference that. But astigmatism is very important to address for cataract surgery because if you don't, then they're going to have streaks of light postoperatively. They're going to have a blurry vision, and if you don't manage it, they're more likely to have to use glasses for both near and far. In a broad overview, there's 2 general ways to adjust astigmatism during cataract surgery. So let's go back to our drawing. If you remember, when we do cataract, we can put a lens in the same spot where the cataract used to be. So you can, during cataract surgery, put a lens here that neutralizes and reduces astigmatism. And the name of that lens is called a toric lens. The other way to manage astigmatism while we're here in surgery is to target the cornea. It's been well known for decades now that the cornea, when it is cut, its shape remodels. So back in the 1980s, this was utilized to do the radial keratotomies. So the 1980s, starting in Russia, they were doing radial keratotomies, or RK. By taking a blade and making cuts through the cornea, we were altering the shape of it. And using nomograms, you can sometimes predict pretty closely how the eye will turn out. So back then we were doing cuts in the cornea, horribly so, like that. And by doing this, I never did it, but this was treating for myopia. So cuts change the shape of the cornea. And we see this even to this day. If someone has a ruptured globe, let's say you are an electrician and you're working on a wire and you slip and your tool cuts your cornea. And the cut makes a linear laceration like this that needs to be stitched. Well, after the stitches come out, now your cornea shape is going to be altered by a degree based on the length of the laceration, which is here to here, and also the proximity to the central corneal aperture, the central optical zone there. So those factors matter. We can utilize some of the history of knowledge of RK and corneal lacerations during our cataract operation to either A, alter where we do the incision. We can do our cataract incision on the cornea here, 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 anywhere. We can go any clock hour. So what we normally try to do is we try to do our incision on the steepest axis of the cornea. So if your steep axis is here at 180 degrees, that is the perfect place to do our incision, because a lot of cataract surgeons notice that when you do your incision here, it's going to reduce or change the corneal curvature in that axis where you did your incision by anywhere from 0.25 maybe to 0.75, depending on what type of incision you make. It can change or reduce the astigmatism by that much. That's just by incision management. So anything on the cornea, we're going to call that corneal cuts or corneal incisions. Or cuts. That's going to alter astigmatism. So we really like to look at where our cornea steep angles are. On our cataract patients, if we're looking to manage astigmatism, we're looking at topography, we're looking at the shape and the parts of the cornea that are steepest. Because now I can just, without doing anything extra, I just change the angle where I enter the cornea, and that will help reduce astigmatism. Now, generally speaking, if there's astigmatism and it is more than 1 diopter or so, we generally want to use a toric lens to do that. If it's less than 1 diopter, probably don't need a toric lens, because less than 1 diopter, you probably can just change your incision, or notice the incision might only change at 0.25, or we can do 2 subcategories here. Number 1, this is called an LRI, limbal relaxing incision. So basically with this, the LRI, we're going to use our nomograms based on old data. We're going to look at the cornea and we're going to cut using a diamond, with an exact depth. We're going to cut through the cornea on the steep points, like here and here. So let's say your steep axis was 90 degrees. We're going to use the diamond blade to make an incision along the edge based on these formulas. And the diamond, by cutting the cornea, by making extra cuts in the cornea, we're going to relax it to reduce the astigmatism. So if you have like 0.7 cylinder, you cut the cornea on the steep plane and that'll reduce the astigmatism, bring it closer to 0. The other way is if you use the femto laser, The femto laser can do it for you. You don't have to use a diamond blade, and it's going to be perfectly centered to the center. It's going to be perfectly measured to the degree, and we call that maybe circinate relaxing incision. Or arcuate relaxing incision. And it's done with the laser. So the laser is actually going to cut the cornea for you. So generally speaking, if you have a patient with some astigmatism, whether it's moderate to severe, like this, or whether it's maybe more mild, we're going to want to treat that too. And some studies, they say maybe 2 out of 3 patients having cataract surgery will have some form of astigmatism that warrants therapy. It's quite a bit. I don't know if it's actually true, because I don't think ours is that much, but yeah, some people say 2 out of 3. That's why when we're doing our preoperative assessment, we're looking at the K values, the corneal curvature values. What is the axis? And can we manage that? Toric, if it's more than a diopter. Less than that, we're looking at some of these other methods. Does that help on the toric part? And this goes whether you're multifocal, whether an extended range, Vivity, it goes for all of them, because if you use like a panoptics lens, it has toricity built into it. It will automatically correct it too, because our panoptics lens comes with astigmatism to some degree.
When do we have to do the laser cuts or LRI with a panoptics lens? Like, to what degree does the panoptic lens correct us?
Usually, if the panoptics lens is our choice, if we want a multifocal, and it's moderate to severe, we're going to use the lens that has the toricity built into it. So then I'm not going to need to do this. But let's say you have a multifocal patient who has 0.7 cylinder, where the toric lens would overcorrect it, we'd overshoot our mark, then I'm not going to use it. It'll flip our axis. I don't like that. So we'll probably use the multifocal lens and combine it with an LRI or a femtosecond CRI. That's how you decide. It's the severity. So remember, severe up here, mild down here. That's how you decide. And actually, if there's less than 0.5 or almost 0, you don't need to do any of that. You can just do regular cataract surgery. Generally speaking, the tolerance for the multifocal lens, you do want it less than 0.5 cylinder when you're all said and done, if you can. And those are going to be the happiest patients, or ideally 0. But the happiest patients are less than 0.5 on the cylinder, and they'll get to that good vision afterwards. So that concludes our lecture about cataracts in general for our ophthalmic technologists. If you find the information format useful, then please don't forget to hit the like button, subscribe, it really helps this channel out. And also, if you like this format, I'm going to place a link to the playlist here where we talk about other broad categories of topics in ophthalmology that you might like too. Until the next video, I'll see you on the next one.